Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Hi, welcome to Melanoma Matters. My name's James Larkin.
And I'm Sapna Patel.
And today we're going to be talking about CheckMate-204 and brain metastases from melanoma. Sapna, over to you. Tell us all about CheckMate-204.
Yeah, so CheckMate-204 was a U.S. study for the treatment of brain metastasis. It was a non-randomized study that looked at nivolumab and ipilimumab. The original publication, the one that we're citing here, is New England Journal of Medicine, 2018. Hussein Taubi is the first author. Kim Margolin is the senior author, and the title of the article is Combined Nivolumab and Ipilimumab in Melanoma Metastatic to the Brain. So this was considered a phase 2 study, open label, like I said, non-randomized, run in the US only. And it was for untreated brain metastasis, or at least one untreated brain metastasis. They applied the RANO criteria, which is 0.5 centimeters or greater. And then this report described efficacy in the asymptomatic population. So those without neurologic symptoms and those that were not on steroids. The primary endpoint, just a little detail here, this was what they called intracranial clinical benefit. So that means a complete response, a partial response, or stable disease. I think they said stable disease at 6 months, for at least 6 months or so. So they were looking at benefits specifically in the brain. They also looked at extracranial response, of course, and then globally they pooled these two responses together. But intracranial clinical benefit was their primary endpoint.
Yeah, so what's the bottom line? What's the take home, do you think? So the original report was NEJM, and I think there's a follow-up, I think, in Lancet Oncology, probably a couple of years ago now, so which is probably 3 years. But what's your take home?
Yeah, so, Kim Margolin and the cytokine working group was one of the first to show the efficacy of ipilimumab in the brain. And so this builds on some of that. That work said if you were symptomatic, there wasn't much benefit, but if you were asymptomatic, there was a little bit of activity in the brain. And the same here, Nivo-Ipi is active in the brain for asymptomatic patients. It had a 55% intracranial clinical benefit rate. Fortunately, the majority of that is complete and partial responses. So very few of that is these stable disease at 6 months, which, could have swayed these numbers. But, it was, I think, 26% complete response rate in the brain, 30% partial response rate, and 2% stable disease for more than 6 months. The extracranial response rate, or the extracranial clinical benefit rate, same, 56%. And so globally, it shows that it's pretty beneficial both in and out of the brain. I think that's the takeaway. If you have an asymptomatic untreated brain met measuring at least 5 millimeters or 0.5 centimeters, there's activity with this combination.
So is the brain in this context just another site of metastatic disease, to ask the question that some people sometimes ask, or not? Is it different, from liver or lung or, lymph nodes?
Yeah, we know it's different because the immune microenvironment's different in the CNS space. It's harder to traffic your effector T cells there. You sometimes can have an imbalance of effector to regulatory T cells, but of course you do see that in organs like the liver. We use this combination in the brain. I think the real thing that CheckMate-204 taught us is you don't have to send your brain mets patients for radiation straight off. You don't have to do local therapy for these patients. But you're laughing. So what do you do in the UK? Is that not?
I'm smiling. I'm not laughing. The one local therapy, I think, if you got someone with brain mets, you need to think about on day one, depending on how you're set up with his surgery, I think. And it maybe you get patients who, if they need surgery, they've already had it. We don't actually. We sometimes just have people coming with brain mets. So my first phone calls to a neurosurgeon, for someone who's got a dominant, if you're talking about asymptomatic, it's different. But just sort of in clinic, we don't see many patients who've got asymptomatic brain mets. But I'll come back to that in a minute. And then the role of radiotherapy is kind of an interesting question, I think, as well. But before we do all of that, what do you think about single agent anti-PD-1 as a treatment for brain metastases, let's say asymptomatic?
I wouldn't use it. Then I would do local therapy. I don't see much activity with single agent PD-1. That's the ABC trial from Australia. I mean, I guess there's a little bit of activity, but for me, we now have combinations, so I wouldn't think about single agent when somebody has a brain metastasis.
Yeah, no, I agree with that as well. And, I think the systemic standard of care is definitely ipi-nivo. And I think, as you say, the ABC trial, these are both relatively small trials, et cetera, et cetera, et cetera. But I think that's my take home message. And, the other thing I would sort of say big picture here, and I said this in the editorial actually as well, is that when I was sort of learning how to treat this disease sort of 20 years ago when I was at a medical school, having brain metastases was basically a death sentence and people tended to die really quickly. And now we're talking about 3-year data, and it looks like the possibility of cure in some of these patients, which is amazing. And I was really worried at the start when I started using checkpoint inhibitors, I suppose 15 years ago now, that we would see the brain as a sanctuary site, and the drugs would work really well everywhere else, and then we just have loads of patients with dominant, and we don't, which is fantastic, I think. Go on, carry on.
Well, two comments. First of all, I'm charmed to think that you were in medical school 20 years ago, because I was in medical school 20 years ago. I graduated in 2005. So I think it was a little bit longer for you, but point well taken. Certainly in my med school days and my early residency and fellowship days, brain metastasis survival in melanoma brain metastasis was 6 months. So it is great to see, with in CheckMate-204, I think you see a 1-year survival with combination nivo-ipi in these brain metastasis patients exceeding 50%. So now, more than half these patients are alive. That's number one. Number two, it begs the question, what you said here, do we know what our melanoma patients are dying from? So if our treatments are effective until it gets to a sanctuary site, are we sure our patients are not still dying of brain mets, or are they dying from toxicity or other causes? Do we know?
Yeah. Well, no, I think from trials, I'm not sure we really have a clear idea, honestly. We talked about CheckMate-67 a little bit already. I would mainly go to my clinical practice, honestly, which is a ridiculous answer. All the patients we treat, what's really happening with these patients at late time points? No, we don't seem to be seeing brain dominant progression very often for people who've been treated with ipi-nivo, at least. So I'm kind of reassured by that, and I'm still doing quite a lot of brain scans at later time points for people who've had brain metastases in the past and for people that haven't had brain metastases. So I partly answer like that. Go on, carry on.
What does your national guidelines do for recommending brain imaging? Are you able to get it as you just described?
Yeah. So, I mean, we don't really have any kind of binding guidelines in the way that you do for follow-up or imaging. NICE makes some guidelines, National Institute of Clinical Excellence. And obviously we have strict rules about reimbursement for drugs, but in terms of follow-up, it's a bit more relaxed. There's some issues in some places about getting access to MRI scans and not CT, but my institution, we don't have that issue. And I mean, broadly speaking, at late time points, in people who've previously had brain mets, I'll do an MRI brain every time they have a CT or a PET CT. And the ones who haven't had brain mets before, I usually do brain MRI every other time, basically. And then the question is, how long do you follow up the patients for?
Yeah, that's really interesting that you're not restricted. So in the U.S., we have our NCCN guidelines, our national uh, guidelines that describe this, but that doesn't hold an insurance company to how what they're going to cover. So despite guidelines saying, if you have melanoma to consider brain imaging annually, and then if you have known metastatic melanoma in the brain, maybe consider it every scan, we still get denials for this. So we will put in for a brain scan in somebody with known brain metastasis, and it will get denied.
Yeah, it's a real shame, I think. And you do see late relapses in the brain. You just do. It's a fact of the disease. I'm not sure we've got that well characterized, but I think it's important to be doing brain scans. I think the other bit that I would emphasize, and I think this is one of the things that CheckMate-204 and the ABC trial show us, is that if you're going to treat brain mets effectively, they need to be small volume. They need to be asymptomatic, and the patients shouldn't be on steroids. And obviously the problem is if you've got symptomatic brain mets, you're on steroids, and it just gives a situation where it's really difficult for systemic treatment to work. So I'm a little bit obsessed, if you like, about catching brain mets early. And I'm talking about following up stage 2 and stage 3 as well here, as well as people that we know, with stage 4, because someone with symptomatic brain mets who's on steroids. So what do you think about that? Can we apply any of these trials to them, this kind of data, or is that just unsalvageable, do you think?
Well, I mean, yeah, I think we can apply that they don't do as well as asymptomatic patients, but this would still potentially be a treatment option. But we know that the use of steroids when you're using checkpoint inhibitor can really blunt an anti-tumor response. But what you said is so key. You have to be obsessive about picking up small volume asymptomatic disease. The treatments work better in them. So just from a payer standpoint, it has to be more cost effective for them to treat an asymptomatic brain metastasis with finite therapy rather than wait for something to become symptomatic. And we know in melanoma, in autopsy series, it's found in 80% of our patients. If you wait for those to become symptomatic, now you're dealing with emergency surgery, hospitalization use, emergency room use. The cost definitely goes up. So it's a little penny wise, pound foolish. I don't know if that's a British saying or not, but to skimp on the scan rather than just pay for the scan and catch
One would
everything.
hope it was a British expression because it's pennies and pounds, not cents and dollars. But yeah, I don't. I kind of don't know the answer. Yeah, but that. I mean, listen. I mean, the other thing is that we can cure some of these patients with brain mets, and the treatments work loads better if they're asymptomatic. So it's kind of not just about the treatments. It's about actually returning some of these people to normal lives and if you like, economic productivity. So it's kind of crazy, I think. So I mentioned surgery, and just to sort of deal with that, it's obviously by definition mainly going to be people who are symptomatic, usually with sort of one dominant area in a part of the brain where you don't want them to progress or it's already causing trouble. So I guess if you're doing surgery, you get that done first of all. So then the next question is about the role of radiotherapy, I think. What I try to do is avoid radiotherapy if I can. Obviously, in the old days when you were probably even before you'd been to medical school, Sapna, we were giving a whole brain radiotherapy. I'm pleased to say that I think pretty much everyone stopped doing whole brain radiotherapy now. But what about kind of smart radiotherapy? SRS, and not for someone who's got very small asymptomatic brain mets. What about when do you start thinking about SRS, in terms of size, location,
That's a
distribution,
good
that kind of thing?
question. There, I think there's what was done in studies, and then we know there's the real world patient that sits in front of you that doesn't fit a perfect study criteria. So the ABCX trial that's ongoing in Australia right now is looking at the combination of this kind of smart stereotactic type radiotherapy in combination with checkpoint. dual checkpoint inhibitor. I think what happens is when you have a patient in front of you and they are symptomatic from a lesion that your neurosurgeon can clearly say, this is the one causing it. It's on the motor strip. It's causing them their leg symptoms. Then, and it's under 3 centimeters, because in the US, that's typically our criteria for SRS is something under 3 centimeters or so, sometimes even 2.5 centimeters. If it's under that size criteria and it's clearly causing symptoms, then you might be better off zapping it, as we say, treating it with stereotactic radiation. And then if there's remaining brain metastasis that you cannot point to causing symptoms, use the systemic therapy for those. So start with the radiation for a symptomatic one. If you're wholly asymptomatic, I think these systemic therapy trials, ABC and CheckMate-204, give me confidence that you could use that and avoid, this radiation, as you were mentioning.
Yeah, so let's say you've got someone where you're attributing confidently symptoms to a particular brain met anatomically. You just treat that one. You wouldn't be working with a radiation oncologist who might say, oh, well, actually, there's 2, 3, 4, 5, 6, 7, 8, 9, 10. We could treat those as well. I mean, how would you deal with that if they said that to you?
Yeah. I mean, that is the conversation, right? This is the conversation you have to have, which is, why don't you treat the one so that I can get them off steroids or relieve their symptoms? Give me a shot with my 2 to 4 doses of Nivo-Ipi, and let's see how we're doing in the brain. I think the concern early on with the 204 and the ABC trials was, does this combination lead to more inflammation and swelling of these tumors? And then that causes symptoms. So I think you have to tread that carefully. There is a fairly high discontinuation rate with this combination, even in the brain. But I think you've got to hold your radiation therapist back, because you can use them to salvage. But, if the systemic therapy is effective and, like you said, returning these patients hopefully to functional status, normal function, normal, maybe even duration of life, then that we're only seeing that with the systemic therapy. I'm not sure we're seeing that with local therapy alone.
No, I mean, I think that's an important point that there's 2 bits to this. I think it's only really effective systemic therapy, and we're talking about immunotherapy checkpoint inhibitors here, really, that's going to change the natural history of the disease. I mean, we haven't talked about BRAF targeted therapy, but I guess briefly, we know it can have some benefit in the brain, but it's usually relatively short-lived. And then this other thing as well about the post-mortem series is quite an important point, I think, that, you might have someone and you think they've only got 1 or 2 brain mets, but it's very, very unlikely they've only got 1 or 2 brain mets. In reality, there's almost always a load of brain mets that are below the resolution of scanning. And then, maybe, almost everybody with kind of, let's call it bad metastatic melanoma, even if they haven't got brain mets on the scan, it'd be very surprising if they didn't microscopically. So it all comes back to systemic therapy, doesn't it? So practical question, what about the timing of systemic therapy and SRS? Do you have strong views on that? One before the other, A before B, B before A, together?
I don't know. Maybe you can teach me if there's some data in this space. What I do, in clinical practice, our radiation therapists don't like to overlap with the checkpoint inhibitors. So they don't like them to be receiving checkpoint and radiation essentially on the same day or the same week. But as far as,
because the drugs have got such short half-lives.
I know. Yeah. Well, so I mean, the real, I mean, your point is well taken. It's in the system. You're getting concomitant therapy if you're giving it anywhere within 100 days of each other. But they don't like us giving it in the same week. Which order it comes in, I think, comes down to that same argument. You're basically giving it concomitantly either way.
Yeah, that's what I think as well. And I mean, with my colleagues, what I tend to do, honestly, is if I see a new patient with brain mets, they'll normally come to me first, make sure that they don't need surgery. Then I would treat them with Ipi-Nivo as soon as I can get a slot to treat them with Ipi-Nivo. And then usually at the same time, I'll get in touch with my radiation oncology colleagues, get them to look at the scans. They'll see the patient, then have a bit of a chat about the radiotherapy. And I think similar to you, there's something obviously symptomatic and suitable for treatment. They'll probably treat that. But I would also sort of try and ask them not to treat other lesions, which don't obviously. And some of the questions. I mean, there's the ABCX trial. You've mentioned that already in Australia, but one of the things I'm still worrying about a little bit is the later complications of stereotactic radiotherapy, and I'm not really sure we have great data at the moment. And I think in my kind of heart, I suppose, if I can avoid we can avoid giving patients radiotherapy, I try to avoid doing it at all. And,
I mean,
and my yeah, go on.
it's no small consequence, but when you do stereotactic, you actually are making a hole in the brain that will never grow back. I mean, you are doing that. So that's a good point that there could be some, we sometimes see down the road radiation necrosis. And we have had some terrible cases of radiation necrosis that leads to somebody's functional decline and ultimately their death, because there's really not a good way to manage that, even if you use VEGF inhibitors and so forth. And then this necrosis is basically tearing away at the brain, causing more and more problems. So that's a good point. The SRS feels good now, but it could have some long-term dire consequences.
Yeah, there's some striking language in there.
Yeah.
Holes, tearing. Uh, but no, I completely agree with that, and it would be good to have some data. I think in due course is one thing to say.
I think, but your
Go on.
question about sequencing, I think, is so good for anybody who's listening, who's practicing in the real world. There's trials where you can design these things where you say this comes first and then this comes next. But in the real world, the flow of your clinic and your referrals is going to dictate what order this happens in. So I think the takeaway is it really doesn't matter if your neurosurgeon gets them in quickly and does the surgery first, or does the SRS first, the stereotactic radiosurgery, the radiation to the brain. If that ends up getting scheduled faster than an infusion spot, if insurance clearance for radiation takes longer than systemic, it almost doesn't matter, because in the real world, your clinical flow is going to dictate how you treat these patients.
Yeah, no, I think that's a really excellent point as well, to take away from this. I was going to make a couple of other points actually. One of which is talk about again about the ABCX trial. For me, the interesting thing when we see that being presented in due course will be really looking at the characteristics of the patients in the trial. And my concern sometimes, that it's a great trial, is that the question in my mind will be, are those the patients that I'm really seeing in clinic or not? And the kind of thing I'm thinking about here, which is weird, is I treat kidney cancer as well, 50%, and there's some trials a while ago of cytoreductive nephrectomy in kidney cancer, which is sort of reported out and everything, and then I kind of look at the trials and then I think, well, is this a patient that I see in clinic? So I think that's a slight risk actually sometimes, that with both of these things, cytoreductive nephrectomy and the treatment of brain mets, there's quite a lot of strong views out there about how one should do it, and I'm guilty of that myself, and that probably reflects the lack of data, I would have thought. And so that's one thing that I would stress. And the other thing I was going to mention, I don't know if you and I have talked about this before, is in the old days, quite a while ago, we'd have someone sent to us with symptomatic brain mets, edema, on steroids. And what I would do in clinic is I'd try and wean the steroids to wait, and then start their checkpoint inhibitor, which I stopped doing quite quickly, because there's some patients you just can't wean steroids. For symptoms, and so I switched basically to giving people ipi-nivo as soon as I could, and then wean the steroids afterwards. And I think, talking to people around the world, I think that's quite an important practical thing. And I say to my kind of my team, fellows, residents in sort of the US nomenclature, you can't respond to drugs unless they're in your body. And I made the mistake at the start of waiting sometimes for weeks, and then you end up with someone you can't even treat. And although the drugs don't work as well in symptomatic patients, they really still can work. And actually, I've seen some Lazarus-like responses in very symptomatic people on steroids. So I think you have to counsel the patient, obviously, that the chances of success probably aren't high, but I think pretty much everybody's worth treating in this situation.
You're right. I mean, if you can't get the drugs in them, then they won't work. And what's the ultimately you don't have too many options when somebody's symptomatic on steroids, so
exactly. Okay, so I think we probably need to wrap up CheckMate-204 there. We've talked about quite a few other things actually, but the bottom line in terms of the systemic treatment of brain metastases from melanoma is I think we and pretty much everyone agree that the systemic standard of care is ipi-nivo. We probably want to start treatment as soon as we can, and then we need to think a little bit about the role of local therapies. And something actually we didn't really say, but I'm obsessed about as well, is that I think the patient should be on the very minimum amount of steroids that they can. And sometimes you have to wean steroids actually quite quickly, and the patients get more symptomatic and you put them back up again. But I think in clinic, that's something you really need to do. So thank you very much, Sapna. And
thanks, James. Hey, everybody, a quick fact check for CheckMate-204. I think we're just forgetting to mention the actual core articles in these recordings. We're probably just getting too excited. So CheckMate-204 originally published Hussein Taubi, first author, Kim Margolin, senior author, New England Journal of Medicine, 2018. And then long-term follow-up was published, same authors, Hussein Taubi, first author, Kim Margolin, senior author, and that was published in the Lancet Oncology in 2021. So those are the core articles that go along with this episode. There's a point, it's probably around the 4-minute, 45-second mark. I'm just fact-checking something James said. He starts laughing. And then I said, well, you're laughing. And he said, no, I'm smiling, not laughing. So I just fact checked that. He was definitely laughing. We also asked, we were joking about the phrase penny wise, pound foolish. It, of course, is a British phrase. It just means being overly cautious about small amounts of money and then not so about large spends. So that's really it. CheckMate-204 is a, great study. We're obviously using it in the real world. Ipi-nivo for CNS metastasis, and hoping to see that Bluebonnet trial results soon. All right.